Hello, everyone. I'm Dr. Manju George, the Scientific Director at PALTOWN Development Foundation, the nonprofit that supports COLONTOWN. We are very happy to have Dr. Aparna Parikh with us, and she's going to talk about colorectal cancer strategies to make cold tumors hot. And just a little brief introduction about Dr. Parikh. She completed her MD from the Indiana University School of Medicine, residency from Mass General, and fellowship at UCSF. She's board certified in internal medicine as well as medical oncology. And she has a lot of nice papers. The most recent one is in Nature Cancer on radiation therapy and immunotherapy. And we are really excited to have you here with us. Take it away.
Great. Thank you so much, Manju, for inviting me. I want to just thank Manju tremendously for her incredible collaboration with a lot of our work that we're working on, kind of pan stages of colorectal cancer. And I've gotten to know her through our Standing Up to Cancer Colon Dream team and her advocacy and voice in our adjuvant study. So, there's lots of different areas where I sort of thought we could talk about today, but in light of our recent paper and some work that our disease group is working on, I wanted to share some of the strategies that we're looking at in the metastatic setting to make some of these cold tumors hot in colon cancer, but as well as other GI cancers. But I'm hoping today that we will leave ample time for discussion. And I know Manju had asked me to just briefly also comment on the status of our stage 3 ctDNA trial, as well as the study that our group is doing that's being led by Ryan Corcoran in the BRAF setting. So I will kind of go through this deck and we'll have some questions, and then I'll give some brief updates, and then we can close with a Q&A, which I think would be very, very much welcome to me as well. So I do apologize if some of you attended AACR colon, because this is somewhat of a repetition of the talk that I gave there. But I hope we'll be able to spend a little bit more time in terms of our next steps from these first generation of trials in this setting. So here are my disclosures, and as part of this, do need to mention that I am discussing investigational use of IPI and NIVO, as well as 3TC in colorectal cancer. So this is a slide that won't be new at all for this audience, but it's one of my favorite slides, just in showing the gains that we have had from the 80s. But, except for biomarkers subtypes, really since 2014 with the pivotal 80405 first line study for the RAS wild type patients, haven't really seen a slope increase where we need it to be in terms of where we are in 2021 and arriving on 2022 soon. I think it's always helpful to put in context where our median OSs are for the latest non-biomarker selected drugs, such as Rego and Lonsurf, where Rego was FDA approved first in 2012 and subsequently Lonsurf in 2015, where we see median OS is still less than 2 months. And except for these biomarkers, which I'm not diminishing the role of these biomarkers, because in summation, these biomarkers do add up, and a lot of exciting work obviously happening in the BRAF V600E and other activating non-V600E alterations. The tremendous gains that we've seen in MSI disease over the last several years, the HER2 and the trastuzumab deruxtecan data, as well as several other small molecule inhibitors and TKIs for the HER2 setting, and then rapidly evolving G12C plus, D, V, and others in that space too. So not diminishing the importance of predictive biomarkers and the great strides we're making in those particular settings, but I think it's really humbling to, look at the Rego and Lonsurf data and put that in context of, where we need to go. I personally just if we're sort of having a doc talk, I don't even really use Rego. I do use Lonsurf if we don't have a good trial option, because do see patients, no great biomarker of who those patients are, but do have patients that do derive benefit for quite some period of time. But in now kind of 7 years sort of being an attending just with Rego, haven't seen anything. And as you all know, toxicity is tough, but do use Lonsurf. So this, again, for this audience, isn't going to be news to any of you, but I think just goes to show that the PD-1 story in colon cancer has actually been around for some time, as far back as 2010, where we have tried to use PD-1 therapy without efficacy. So if you look at sort of summary of the numerators and denominators, very humbling numerators, with a non-trivial number in the denominator in terms of MSS patients that were treated with checkpoint inhibition. I think just for time, I'm going to skip over the MSI data because you guys all know the Keynote 177 data, but again, noting which many of us are paying close attention to, including approaches such as using ctDNA in this setting to try to really understand who these patients are that are dropping off early. So when you look at the Keynote 177 data, the thing that I always like to point out is in the Pembro group that you had a 30% non-response rate. And so even for these patients, even though we have made tremendous headway with the MSI patients in Pembro and Nivo-Ipi, what are the biomarkers that are predicting lack of response here? And can tools such as ctDNA be used as a guide to predict who those non-responders are going to be and potentially salvage an opportunity to switch to chemo sooner rather than later for those patients? This cancer kind of immunotherapy cycle is, again, not a figure that's new to the field and was kind of a figure that initially came out of Ira Millman and colleagues, but really shows us at the cellular level what the problem is with these cold tumors and the various checkpoints and opportunities we have to try to engage tumoral responses. So some of the things that we're going to be talking about too is not only where we're looking at removing the brakes with the checkpoint inhibitors, but I think a lot of interest in the TGF-beta, the CMS4 colon cancers too, and how we can, really help with infiltration into tumors, both enhancing the chemotherapy response, but potentially other signaling pathways such as TGF-beta to try to hinder TGF-beta signaling and allow for kind of immune trafficking, but also efficacy of chemotherapy. And then what we're trying to do with some of our approaches here, are there ways for us to kind of stimulate antigen presentation and basically stimulate an in situ vaccine response to try to get these tumors from here over to the left to the right side of this diagram. So we at MGH have a very radiation heavy group, kind of a phenomenal group of radoncs led by Ted Hong, who is the NRG chair. And because of that, we entirely recognize that not only in colon cancer, but rectal cancer, pancreatic cancer, we're a very radiation biased sort of group, and do a lot of trials and work to try to exploit radiation as a tool. And some of this work actually came from the Penn group initially, and the Min and colleagues now several years ago that showed that using radiation and dual checkpoint inhibition may actually activate non-redundant immune mechanisms. We've seen several other kind of studies in other tumor types, such as lung cancer, GU cancers as well, showing that low dose radiotherapy may actually help your tumor presentation and prevent the resistance to immunotherapy that is happening. It is very controversial what the right dose of radiation is and whether one-time radiation is sufficient or not. I actually think that you may need to give subsequent doses to kind of create that T cell repertoire and maintain that T cell response over time. And maybe a one-time or a couple of doses of radiation isn't going to be sufficient. But if you look here with the MIN paper here with the preclinical data looking at the control in the gray here, but combining the control with RT and CTLA4 and RT, again, responses here in the preclinical colon cell lines. So based on some of that work, and they used sort of an 8 gray times 3 fractionation schedule, and that's what we ended up ultimately taking into the clinic. So it's complex. I think it's one of these things that we're really trying to understand what is happening. But we do know that it does seem that radiation is helping promote T cell infiltration, antigen presentation, and shaping your T cell repertoire. We see that the responses that are happening to radiation seems to be happening in an interferon dependent manner. So really activating the innate immune response and not just sort of adaptive immunity. There is some evidence preclinically that there is actually, through the kind of cellular processes and turnaround that are happening with the low dose radiation, where you're not exhausting your T cells or burning them out, that you are releasing tumor specific antigens, and with those tumor specific antigens, mounting a direct T cell response to that. And we know actually that RT activates dendritic cells as well. And one of our lab collaborators who works in Nir Hacohen's labs, Nir Hacohen's lab, Arnav Mehta, is really trying to look at some strategies using TLR9 and others to, right now in pancreatic cancer is where he has funding to try to look at dendritic cell activation with kind of TLR9 agonists and RT. We know that anti-CTLA4 promotes the expansion of T cells, inhibits Tregs, and effectively increasing your CD8 Treg ratio. And that PD-L1 blockade may actually reverse your T cell exhaustion and help mitigate that depression in your CD8 to Treg ratio further. Again, the idea being that we're trying to get a, oligo clonal T cell response here, even though we are going to be getting, polyclonal responses. Really, the idea here is there a way to, figure out a way to get that oligoclonal T cell expansion and response, and then, help subsequently with your T cell infiltration. And can we use these combination of approaches to really kind of harness what radiation is able to do? So given this, we embarked on a trial. It was a single institution trial funded by BMS with correlative supported by Stand Up to Cancer for the colon component. It was a trial that combined colon cancer, pancreatic cancer, as well as MSI disease. We haven't completed the MSI cohort yet, but did complete the MSS, CRC, and pancreatic cohorts. And what we did here is we gave Nivo and Ipi at cycle 1, day 1, and then cycle 2, 6 weeks later, we gave Nivo and Ipi again, and we gave 8 gray times 3 to a single lesion that was radiated. And what's important to note here is that the lesion we radiated was not the lesion that was measured. We are pooling the data to look at the radiated lesion response, but currently what we reported and what the endpoint of the study was to look at response outside of the radiated field. And then we completed, we continued Nivo and Ipi after that initial 8 gray times 3 to a single lesion beyond that initial treatment. So here were the concert diagrams for both cohorts. For colon, we had 40 patients. I do think it's important to note for both cohorts, we had, around a 30% drop off from the start of Ipi and Nivo to radiation. And so I'll show you the data for both the all-comer population here, sort of the intent to treat, but actually what we call the modified intent to treat, so the response of people that actually went up to go on to receive radiation. And what you can see, the reasons for discontinuation, toxicity was a few. I think keeping in mind that when we started this study in like 2016, 2017, Ipi and Nivo was still relatively new to the GI space. So we were sort of figuring out how to manage, the colitis and others, where we have made a lot of headway in the recent years of within the GI community, how to handle those side effects. But we were still, learning how to safely, give these drugs at that time. We had 9 other patients that had PD. This was a heavily pretreated patient population. So unfortunately, by the time you register the patient and actually start treatment, we had 9 patients that dropped off, and ultimately we weren't able to get to radiation. And so when you look at the per protocol analysis, so these were people that actually ended up getting radiation, so not the all-comer. We see a disease control rate of nearly 40% and an objective response rate of 15%. And what I want to call attention to is the duration of responses in the patients that were deriving benefit. So if you look here at the kind of CRs and PRs, as well as the stable disease patients, we didn't put this figure in the paper, but we actually did map out the previous lines of therapy for these patients and how long they were on their last previous line. And I think what was notable to us was that, for a number of these patients, the duration of treatment is exceeding a year. We don't think that was just sort of biologically selecting patients, because again, when we looked at the previous line of therapy for those patients, it wasn't quite nearly a year by any means. There was only one patient that had lung-only mets. She wasn't a PR patient, but she was a stable disease patient. And so sort of lower volume lung-only disease, that her biology was clearly favorable. But besides her, we don't think that this is sort of a fluke in terms of biologically selecting favorable patients. All right. So here is just one example of the out-of-field responses. So this was a patient that I shared with Ted, and we did not pre-specify in the protocol what needed to be irradiated. So Ted Hong or his colleague Jen Wu would just sort of pick if there was a lesion that was needed for symptom control or palliation, often would pick that region, or another region that was amenable to biopsy, because we had a lot of heavy correlatives here. And here what you can see for this particular patient, he radiated the liver, and what you can see here is a really nice response in the lung metastases. So these are the same cuts, and you see improvement, here of this lesion, and actually disappearing of some of the other lung nodules that we saw. When we look at the Kaplan-Meier curves, I put the PDAC just for reference here, but when you look at the PFS and OS for the patients that actually went on to benefit or not, 5.2 versus 2.4 months, and then the OS 20.9 months versus 7.7 months for patients that were not deriving benefit. One of the questions, this actually we hadn't done initially, because we sort of assumed it was fine just based on this, and then the reviewers actually asked us to go back and look at TMB, which we did, and not surprisingly, these were all low TMB patients. So TMB, albeit controversial in colorectal cancer, was certainly not the reason that was driving this change. We had 41 samples where we had paired germline and DNA, 17 patients that were actually analyzable with the radiation. There was really no change in TMB before, during, after treatment. Profiling is what you would sort of expect, KRAS, P53, APC alterations. We did note, interestingly, some change in sort of DNA damage response genes, but again, numbers are really small, so hard to really draw a lot of conclusions around kind of any DDR signatures as well. But what was interesting is, when we started to look at, what was coming out on sort of the bulk RNA-seq and what are the other kind of changes that we were seeing, is David Ting, who did a lot of the correlative work for this, was noticing that in the responders, they seem to be enriched in these, again, interferon signature response genes. So, signifying again that something is happening with kind of the innate immune system, and perhaps that these patients that were going on to respond were somehow primed, to respond to this approach. And what we're really trying to figure out is there a way for us to figure out, how can we make more patients sort of primed for this approach, and are there any ways, and I'll show you what some of those ways are to try to exploit this vulnerability for patients. We saw some change in antigen presentation, as well as kind of T cell recruitment signatures before and after radiation. And then we saw this differential expression of these non-coding RNA repeats in all the biopsies from the non-responders from the responders to the non-responders, particularly one repeat, which is called HER-VK. And I'll tell you a little bit about what these repeats are in the subsequent slide or two. Like I mentioned, HER-VK was one thing that came out, but also line 1, which is another repeat. And they're, actually kind of ish assays that are easy to do to ascertain HER-VK and line 1 status. And again, we saw this, and what we have learned in other cancers, actually urothelial cancer, there was a great paper that I put in reference here, and I can make sure Manju has these slides, that basically showed too that HER-VK was associated with response in urothelial cancer, and HER-VK association, or HER-VK has actually been associated with NK activation. So maybe there's something with these non-coding repeat elements that are actually the ones that are driving these tumors to be primed for, responding. And our hypothesis is, and what we're trying to really understand is there a way to exploit these repeats further? So what we saw was that, this strategy of CTLA-4 and PD-1 did show some activity in a subset of patients. I'll show you the schema for our trial that we will have our last patient on this week, and I've finished this next MSS trial to kind of confirm the signals. And with this next trial, we tried to mitigate some of that toxicity fallout. But also, Neerha Cohen and others have done work that's showing that perhaps PD-1 blockade prior to the antigen priming may paradoxically lead to T cell exhaustion. So independent of toxicity, if we expose to the checkpoint inhibition early, can we help with the responses, and obviously the ongoing biomarker work that we're doing. So this was the study that is 30 patients, and patient 30 will come on this week, where we did the exact same thing, 8 grade times 3, but moved Nivo and Ipi up to cycle 1, day 1, and then actually are only continuing with 4 cycles of Ipi, just based on other tumor types, the data that maybe you don't need the Ipi long term. So we're seeing, it's too early. We haven't yet looked at the kind of data. I'm treating a lot of these patients, and so we are seeing some benefit. I don't think it's going to be where we would like to be in terms of 40% response rates, but I do think I know we're seeing some patients benefiting, and we'll see what those numbers look like. And now we're really trying to work, figure out what our path forward is here, and are there better ways to get more to respond, or will BMS support a larger kind of study with this approach? Because as you all know, if you're in that 20% of patients that you're deriving benefit for a while, that's real and meaningful, and it's our job now to kind of figure out with biopharma how to support this. So We're doing a lot of, correlative work with this too. We're looking at ctDNA. We're doing, single cell RNA sequencing. And the way I like to sort of think about some of these immuno-oncology correlatives is it's, the single cell approach is to really understand what is in the tumor. So, what is the composition of, NK, CD8s, dendritic cells, and then what's important is not only understanding what, but using some of these multiplex approaches to understand where are these different cellular components located to try to understand to try to help us understand what's happening. So then going back to the repeats, so this was, something that also actually came from David Ting's lab, and when he was in our chief of the cancers or cancer center director Daniel Haber's lab as a postdoc a long time ago now, and they started to identify, as well as some other groups, these what it's being called as sort of the repeatome, and it's sort of an unexplored facet of the genome, which when I first met with so the backstory is I sort of showed up at MGH, almost 6 years ago too. And David Ting and I met, and he was like, hey, we found this stuff. It's, constituting, 50% up to 70% of, the genome. And we don't think it's just junk. And, he showed me some data that he had in colon cancer, and we started to put our heads together of kind of digging through the data and the repeat landscape. And, was there a way for us to try to think about how to harness these repeats, which, interestingly, these repeats we see in embryogenesis, and you see really high levels of these. And then it seems to be pretty quiescent until expression again in, cancer pathogenesis, but also aging and autoimmune disease. So there's something going on. And I think, from a very simplistic standpoint, it makes a lot of sense. Like, why would something be there? And it must have some purpose. And if they're suppressed, they don't cause problems. But if they are not suppressed, it can lead to problems such as epithelial malignancies. And so this is just to sort of show you that these repeats have actually been around for some time and act like endogenous retroviruses and actually have their own reverse transcriptase. But only in the last few years are we seeing this not only in GI cancers, but a lot of other malignancies in terms of the role of these and how they may actually stimulate immune responses. We know that they represent in the genome like viruses. They have an RT. So different things like methylation can actually help de-repress them. And then you can, have this RT that we think helps them reintegrate and expand into the genome. And this is sort of a nice kind of diagram of, the RNA to the RNA DNA and, rDNA constructs there and how they eventually are reintegrated and expanded. And can we use something like an NRTI to prevent this reintegration and expansion? This was a Nature Genetics paper like a couple years ago that looked at these repeats in several different malignancies. And interestingly, esophageal cancer is one of the higher ones, but you see here colon cancer is another cancer where these repeats seem to be differentially expressed. And like I mentioned, is that we think that these RNA repeats are actually triggering an innate immune response. And with these repeats, we see a lot of these inflammatory cytokines go up. And what you can see here with HSAT2, which is one of these repeats, you can see a difference here between kind of, TNF, IL-6 expression, IL-12. So seems to be something happening with these and interferon responses. This was a JCI paper. David Ting was a collaborator on this, as well as from Bersani and colleagues a few years ago, looking at these NRTIs, so using 3TC, for example, to inhibit these tumor spheres of T53 mutant colon cancer. I won't go into some of the details of how T53 is repressing these repeats, but we do think that actually these repeats tend to be linked to T53 expression. So if you see here, this is line 1 in the green. And if you look at T53 colon cancer versus wild type colon cancers, the P53 mutants seem to be enriched in these repeats as well. So David Tang sort of treated some mouse xenografts with 3TC, and you can look here in pretty standard colon cancer xenografts here in cell lines, looking at what's happening to in P53 mutant tumors as well as wild type tumors in HCT116 cell line versus the xenograft, what is happening with 3TC and tumor growth here. So showing some activity of this in the mutant patients, but not in wild type. So this led us to write a small grant that was funded by a foundation. You can imagine it's really hard to get these funded because biopharma, there's not a clear R&D sort of path for these. So we tried lots of different avenues, and ultimately foundation, the Gateway Foundation, funded this trial, and it was a small study with 3TC alone. And we didn't really think that 3TC alone was going to, I think we know even going forward that we're going to need to look at combination approaches, but we wanted to make this sort of a biomarker-driven trial and see that with 3TC alone and doing biopsies, are we actually hitting the target here and engaging these repeats? And so we did the trial. We started initially at the HIV dosing, which is, or hepatitis dosing too, which is 300 milligrams daily. And we ended up going up to 1200 milligrams daily. And this was actually based on the initial HIV data where there were no DLTs at the 1200, but given the efficacy they saw in the viral space around 300, that's what ultimately was approved. And so we had 9 patients that were enrolled at 300, and then we went up to 23 more patients at the higher dosing. Really no significant side effects, some fatigue, hard to sort out, was that cancer versus drug? And we had 8 out of 32 patients that had disease control, and 1 out of 32 patients that had a mixed response. That one person, the mixed response, did not meet RECIST criteria for response, but had a really nice CEA decline, and then had some tumors that were actually regressing, and then others that were growing, but the CEA overall was coming down. So that's kind of this patient here with the CEA response, and you can see a little bit of CEA response there, and some stability at least here. And when we looked at the patients that were deriving benefit, again, what we saw was that in the responders versus non-responders, the same thing, this line 1 protein, which is another, it's another one of the proteins that is expressed or formed by these repeats. Sort of the line 1 leads to line 1 protein. And we looked at line 1 status, and again, looks like differentially expressed in patients that were benefiting versus not. So that study is, we are under revisions right now for publication, and trying to figure out our path forward with both of these approaches. And, I hope we can all continue to work together as a community, because these are hard studies for biopharma to support, but, we're looking at stand up to other options to try to get some of these concepts through, and our priority options for even when we get patients that are interested in supporting trials and things too. So we're looking at options with 3TC and RT based on the initial data that I showed you from our RT study. We know that these are differentially methylation status can, if you use, epigenetic drugs and preclinical data, you may be able to get these repeats expressed. They seem to be linked to DNA damage and DNA damage response, and as a kind of repair mechanism for double-stranded DNA breaks. And so We have brokered some preclinical contracts with David Ting to look at DNA, some of the DNA damage drugs that are out there, but are really working hard to try to figure out how to exploit these and get patients access to some of these combination strategies. So with that, I think I went a little bit over than I wanted to with the 30 minutes, but wanted to share with you all some of the things that we are working on and where we are headed. So maybe I'll pause for questions and I can give you kind of brief non-slide updates on the BRAF study as well as the ctDNA studies. Does that sound okay?
Yeah, that sounds good. This is really exciting. Thank you, Dr. Parikh. So we have some general questions, so maybe we can go through them like quickly. What is the rationale and risk benefit for triplet chemo, like FOLFOXIRI, in the first line versus, sequential doublets?
Yeah, so I think there is, so there's a lot of institutional bias around this. And in general, I think taking a step back of triplet versus doublet, as well as I think maintenance versus holidays, is a big discussion that I think a lot of people sort of split our hairs around and trying to understand. I do think when you can give FOLFOXIRI safely, I do think that there is it's truly synergistic, right? It's not just additive, and so I do think that there is a survival benefit. And I sort of believe the tribe 2 and studies that for patients, and we've seen this with pancreatic cancer and others, and in cholangio, there was a study that's just looking at FOLFIRINOX and GemCis and didn't show that FOLFIRINOX was better than GemCis. So it's not always just more is better. But for colon cancer, I think we do have compelling data to say that in the right patient who we can get through FOLFOXIRI and in experienced hands with dose adjustments and things, you can get people through FOLFOXIRI. Probably is a kind of survival benefit. So I'm biased. We're a pro FOLFIRINOX group, a FOLFOXIRI group, have been for years, and so I do believe that there is a survival benefit. But I'm also I don't think, not surprisingly, treatment holidays lead to a detriment in PFS, but overall survival benefits are the same. And so I'm a firm believer in quality of life discussions with the patient that you're having and what their goals are, and don't think in the right patients you're going to lose survival by both doing maintenance, but I'm also a believer in good induction.
Okay. So I mean, what would you think, like, would you give it to a younger patient, or would you give it, like, I know that many of the BRAF V600E mutant patients, they get FOLFOXIRI in the beginning, right? So do you use some criteria to decide who are the patients that you would give FOLFOXIRI up front?
So even older patients, that they have good performance status,
Okay.
I feel like, and performance status is in the eyes of the beholder, but we have given FOLFOXIRI or FOLFIRINOX to octogenarians with pancreatic cancer and have gotten them through. So I'm not shy about it, and recognizing that we may have to dose adjust and things along the way. But I think performance status to me more than age
Okay, and then the next question is about re-challenging with, like, say, FOLFOX or FOLFIRI for a patient, later, like 2 or 3 years after they have had those. What do you think about that as part of a treatment strategy? Is it something that you follow?
Very much so. I think we have good enough benefit if, I think if data that if neuropathy and things are okay, that you can regain response, particularly to the platinum. So even with FOLFOXIRI, I should mention, I'm not pushing through necessarily 6 months of FOLFOXIRI, sort of doing a, 4 months, get a response, then I tend to be FOLFIRI pro, just because of the neuropathy issue and trying to save the platinum for later. So, FOLFIRI, Bev, or anti-EGFR, depending on what, sidedness and mutational status, and then giving a holiday at some point in time, and then reintroducing later.
Okay. And then the next question is about, what are some of the conditions at which, under which you decide to stop the chemo and then consider local or regional treatments?
Yeah, so this is it's a good question, and it gets debated all the time because, as you may know, that for example, liver-directed therapy hasn't had a lot of there hasn't been really survival advantages there. But we are a site that I said, for limited limited disease, depending on locations, will, particularly if a patient needs a break from chemotherapy, whether it's toxicity or just fatigue, or has had a good response for some time, and we have shown that we're not going to get behind, have certainly used, SBRT to a dominate liver lesion. And as long as we think we have a good handle of lung, we do, ablation for small volume liver, lung mets, for example. So it's really about following the biology and making sure that the systemic disease isn't going to get ahead of you. And if you feel like you have that window to, stay on top of the systemic disease, but you can, treat a dominant liver met that may cause problems imminently and prevent that from causing problems, in discussion with the patient, sort of understanding that we haven't yet. There's an NRG trial that's looking at oligomet treatment and radiation and things, but I think we're all starting to get a sense that oligomet sort of treatment is probably kind of beneficial. So our group, again, recognizing the biases of not a lot of survival data yet to support these, but in the right patients aren't shy about like organ specific disease control approaches.
Okay, thank you very much for that. There is one question about trials, but maybe we'll go to that later. There are some questions in chat. So any insight on overcoming resistance to G12C inhibitors or ideas on sequencing? Is there any news on if switching to a new G12C inhibitor after failing another one will work?
Yeah, I don't think another G12C inhibitor in and of itself is going to work. I think we are sort of seeing the differences between the G12C inhibitors and which ones are better versus others. But I think the kind of dual triple pathway blockade approach with looking at, better, I think there are better ERK inhibitors that are coming. ERAS is a company that I think has a really exciting ERK inhibitor. I think we're still looking at some of the SHP2 combination approaches. So I think it's going to be combination strategies because, as far as we know, Dr. Corcoran's lab is doing a lot of work in this, but a lot of the resistance alterations that we're seeing, and then what they saw in the New England Journal lung cancer paper aren't necessarily resistance alterations that are going to be able to be overcome with just another kind of G12C inhibitor. So it's sort of combination or downstream approaches too.
Okay. The next question is, how do experts use ctDNA or NGS testing to know when to re-challenge targeted treatments? Like SETX, RAS treatment, BRAF inhibitor, etc. Is there an estimate of for how many months between treatment is needed for optimal possible?
It's a great question. And, you'll see people like Len Sauls argue from Chronos that it's only a 20% response rate, and the GF challenge of persons is really like cost effective and useful. So I don't think we really know. I think we do kind of have a timeline of what we would expect the kind of resistant clones half-life of, a few months in terms of decaying. Sort of 6 to 8 months sort of seems to be that window. What I tend to do at the time of when people are going on either holidays or something else is I just get kind of a every 2 months ctDNA test and sort of see what is happening to those resistance clones. And, I think what's so challenging with even just upfront ctDNA testing is, does a small KRAS clone at 0.1%, does that actually portend resistance or not? And like the dogma now is like, of course, like, yes, KRAS is a resistance alternation and has detriment to anti-GFR therapy, but like if you see a RAS wild type tumor and then you see this small clone, is that really clonal, not clonal? Should you not give that patient anti-EGFR therapy? Like when you have a limited toolbox of things to try, same thing like HER2. I had a patient that, had a RAS mutation, but I didn't have a lot of things to try, but was really, had a HER2 at 25 to 1. So am I going to believe that small ctDNA result and not give them HER2 directed therapy? It's hard not to, right? When you have an amplification that's sort of at 25 to 1. So that patient benefited, but again, the purist would say, KRAS alteration came up and, that's a known resistance mechanism. Those patients aren't getting benefit, but they're not necessarily looking at the fact that, again, that for that particular patient, you had a amplification that was like at 25-1, and clearly your driver event here, and that KRAS was probably just a subclone that, overall wasn't going to hinder benefit. So ctDNA is a great tool, and I'm obviously biased, but it is a tool. And you have to sort of think about what you have in your toolbox to care for the patient individually. And, luckily for, colon cancer, sometimes you have a little bit of time to try one or two things before people fall off, unfortunately, where you may not. That's not always the case. And sometimes you just have to make, your best clinical judgment. But I think we use it as a tool, but not as the end all be all.
Yeah, like with clinical judgment,
With
right?
clinical judgment,
Yeah.
exactly, right.
Yeah. So I had two questions about your talk. So the her VK, that repeat element as well as the line one. So are you seeing that like before treatment itself, you could look at the tumor and see if there is overexpression or?
Yeah. And
Okay.
David Ting did a really great look. He hasn't published this yet, or we haven't. But actually, when you look at, we did a cohort of just neoadjuvant rectal cancer patients that did not go on to have a clinical complete response. And what he showed was that the patients what was left were these HER-VK elements. So it almost seemed to be a biomarker of non-response to just the chemo too. And so what we're trying to figure out is, like, can we make these repeats engaged more to try to therapeutically use them to kind of push these tumors over to response.
Yeah, and I was also curious to see that, like with the mutation, with the TP53 mutation, you're seeing more line expression and things like that, right?
Yeah.
So I would think that ideally, if some of the testing companies, the ctDNA or the tumor testing companies, would also look at these elements, that would be kind of nice to see for your trial itself, to select patients who, in which you'd get a better response, right?
Yeah, so we're working with some colleagues actually at the Brigham to look at a line 1 blood assay as well. And we're trying to validate that with the tumor to sort of figure out, but as you can imagine, like biopharma, so like, what are these, like, what do we do with them? And like David Ting and I are pitching this sort of constantly, like, hey, we have an assay, we can sort of, but it's really hard for them to currently get there. But I think we're getting there.
Yeah, okay, thank you for that. So there is a patient with a POL mutation. It is like a S314A missense variant, and the TMB is 7.4. So she's asking if it'll have an effect in choosing immunotherapy. Like with the low TMB with POL, what do you think?
Yeah, so probably not, unfortunately. I think I would have to look up this particular POLI variant. It may just be a kind of a VUS.
Yeah.
But typically the POLI ones that we're seeing response are like hundreds of TMB.
Okay, thank you for that. I think that we can go for the updates, and then there is one BRAF related question, so we can look at that. So you're going to start with your ctDNA trial, right? First.
Yeah. So the ctDNA trial has had lots of challenges, but we're not giving up on it yet. Some of the challenges came with being a trial that just by nature, the Stand Up to Cancer team was only a Northeast heavy team. And I don't think we quite, like, when the team came together, it was based on the, correlative expertise and clinical expertise, but not necessarily like a cooperative group study. So it was a small number of sites that could activate the study. And then COVID hit. And because it was a stage 3 trial, a lot of our institutions weren't allowing stage 3 trials to continue on because there was, they were trying to improve cure, not necessarily metastatic, where they didn't seem that there were other options. So we had a really big delay, and it was actually only, we've had around 40-ish patients at MGH, and it was only the last couple months that MSK and Hopkins and Cornell all came on board. So I think we'll see now a rapid increase there, but we're behind. But I think the Stand Up to Cancer, even though the team is over, is still really committed to the question, and they're not we're not pulling funding from it. So we're continuing. And, I think Manju, I had mentioned to you, and a lot of controversy around rectal. We were getting close to adding rectal, but people were very concerned that if we added rectal, that in data may be hard to, we would get a lot of challenges about the meaningfulness of the data if we didn't stratify it. And we ran the stats to stratify for rectal was gonna, it's already a 400 to 500 patient study to try to find 80 patients that are ctDNA positive after treatment. And to give you a sense of that, almost 40-ish or so patients we have, it's good. We don't want to be seeing positive results. Could you try again? But we're not seeing a lot of, was that my watch picked up something?
Yeah.
We're not seeing a lot of positive patients yet, which is good. But it's not yet enough to sort of show that we're able to, I don't have it yet. I can't tell you yet if we're seeing a signal of clearance or not with a small number, but committed to continuing the study. And then I think mainly the updates from it that may not be yet even on the clinicaltrials.gov was the HER2 edition, which I know I mentioned to you.
Yes.
So we have the cohorts that are just the MSS getting FOLFIRI if they're ctDNA positive versus randomized to a little bit more stringent surveillance than you would get under the NCCN guidelines. And then we have a Nivo arm for the MSI positive, a HER2 arm for the HER2 amplified positive, and then the BRAF arm for the BRAF positive patients.
I think that we're like focusing or showcasing some of the trials in the COLONTOWN University website. So I think this might be a good trial to showcase. So maybe I'll reach out to you after the call. So and then about Dr. Corcoran's trial.
Yeah, so no updates since ESMO. We haven't looked, so that's the last update. But we had an expansion that already filled that BMS gave us for additional patients. So we're looking through all of that now. Still have MSI BRAF spots open, but the kind of BRAF MSS is finished accrual, and so now we're looking at all their data.
Okay.
I think he's
that's
hoping.
good.
I think he's hoping to. I think we're hoping to repackage it maybe for GI-ESMO.
Okay. July then. Yeah. Okay. So and then this question: some BRAF V600E patients in other countries are trying to replicate Dr. Corcoran's and Dr. Morris's trial, checkpoint inhibitor plus BRAF. Prior BRAF or IO, how has it affected results? Yeah, I think that he was allowing prior BRAF IO, and then he stopped that, and now you're not accepting it, right?
We're not, because it actually seemed to be the patients that were benefiting first were the untreated BRAF patients. So there were a few patients that had prior BRAF directed therapy that seemed to be benefiting, but it seems like the patients that were deriving the most benefit were not treated patients.
Okay. Yeah. And then I think we have covered those questions. I was really interested in seeing that the 3TC results, so are you planning trials? How can we help?
We are pitching it to a bunch of different people. So we have 5 or 6 different schemas with different combinations with radiation, checkpoint inhibition, with epigenetic drugs. The epigenetic space has been really tough for solid tumors, right? And so the companies that have, guadocytabine, Aztecs, and, AZA, they just, given the challenges they've had in solid tumors in the past, haven't been too keen on a development path for solid tumors. So we're trying. We're looking at potentially there may be some opportunities just to do via cooperative group or Stand Up to Cancer, for example, just in a neoadjuvant FOLFIRINOX setting for rectal, sort of a proof of concept with 3TC and radiation. But we're trying. We're looking. We have some concepts brewing with ATM and ATR inhibitors plus 3TC and IO. But it's biopharma is tough.
Yeah. So again, in that also, are you seeing the line expression and the TP53 mutant So I mean, actually, if you with patient selection, you should be able to get patients, and I mean, viability, feasibility wise, it will be a great study, right? Like,
Yeah, so I'm hoping, I'm hoping what'll happen is once if we can get these revisions out, it's at a pretty high profile journal right now with kind of some major revisions. And so I'm hoping if that paper comes out in combination with this Ipi-Nivo study, people will kind of believe the story a little bit more. And then we have the tools, like we know how to select for these patients. So we're not giving up.
okay, okay. I think the last question is about, promising trials for all wild type MSS patients. I mean, for your patients, what are some of the things that you look for?
Yeah, it's, I think we're trying to look at some like opening some new ADCs that are coming in the phase 1 world. I'm not gonna lie, I'm not too keen. We're opening them because I think they're good options to have, but some of the VEGF IO trials, I think we'll just have to see where these PEM, lenvatinib, rego, and approaches. It's interesting, you wonder if there are certain patients like liver metastases patients where that may be more beneficial, and so it's a little bit hand wavy now, but given kind of the responses we're seeing with the TKI VEGF combos and HCC, is there something about like liver mets or primary HCCs that would allow those patients to benefit more? So very much looking at combination studies, but I think ADCs are another area that we're kind of paying attention to in terms of companies that may have ADC for MSS disease. I think the other challenge with the MSS, which I don't quite understand why biopharma hasn't quite adopted, is sort of really looking at subsets of patients, right? We know like there was a TGF beta trial that ended up not showing the company ended up not deciding to put in colon cancer as an expansion cohort, but they didn't select the right patients, right, that are kind of high stromal driven patients. And so I think as we're having conversations, trying to really encourage them to think about what the biomarkers are and what are, if it's not CMS, is it things like this that can help us select patients.
Yeah, it makes sense. So are you looking at the two ADCs, like the HER3 and the TROP2, those ones? Okay.
Yeah. And the TROP2, I think there are some, they're looking at it potentially in the adjuvant setting too, using ctDNA too. So, yes, so exactly, the HER3 and the TROP2.
Okay. And then like in your talk, you mentioned we're almost at time. In your talk, you mentioned that you're not a fan of Stivarga, regorafenib, you choose Lonsurf. Like, are you seeing that kind of a difference? Because in the trials, they say they're kind of comparable, but is there a larger number of patients that respond to Lonsurf versus Stivarga?
I think so. I think I've seen true responses with Lonsurf, and these are, platinum refractory, 5 FU refractory patients. Stivarga, I've had very, 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 very limited actual, like some disease control, but I just haven't seen, I've seen maybe one true response.
Okay.
Getting to dosing at 160 is also really tough.
Yes. Okay, it's 2:00. Thank you so much. This was amazing. And then the recording will be posted in COLONTOWN University. And thank you so much for your time and all the information.
Thanks.
Thank you all for attending.
Bye.
Take care. Bye.